Hi, I'm Anne Woolfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound Podcast, bringing you up-to-date information in all things O&G. Today, we're exploring the magical world of Placenta Accreta spectrum. Placenta Accreta is like the Lord Voldemort of obstetrics. If we know about it in advance, we can prepare ourselves and put up a worthy fight. But if it surprises us out of the blue, it really catches us off guard. So let's equip ourselves with the knowledge we need to be able to defend ourselves against the dark arts of Placenta Accreta spectrum. First of all, we need to know who we're dealing with. What exactly is Placenta Accreta spectrum?
Placenta accreta spectrum is an umbrella term used to describe the abnormal adherence of the placenta to the underlying uterine wall in the partial or complete absence of decidua. It includes 3 different subtypes: placenta accreta, placenta increta, and placenta percreta. Placenta accreta is where the villi adhere superficially to the myometrium. Placenta increta is where the villi penetrate deeply into the uterine myometrium. And placenta percreta is where the villi perforate through the entire uterine wall and serosa and even invade surrounding organs. You can remember this one because percreta perforates. Placenta accreta spectrum can also be classified as total, partial, or focal, depending on the amount of placental tissue involved.
FIGO has also created a classification system to describe placenta accreta spectrum. Grade 1 refers to abnormally adherent placenta or accreta. Grade 2 refers to placenta increta, and Grade 3 refers to placenta percreta, and it's further divided into 3A, which is limited to the uterine serosa, 3B, which involves the urinary bladder, and 3C, which involves invasion of the placenta to other pelvic tissues and organs.
How in the world does this even happen? Like, I thought placentas were way smarter than this.
Placentas are truly amazing organs. There are very few sites where a placenta won't start to grow. Think about tubal ectopics, Caesar scar pregnancies, and even abdominal pregnancies. As to whether those placentas can sustain a pregnancy or not, well, that's a different issue. When an embryo implants in the uterus, the decidua is thought to regulate the depth of trophoblast invasion. When a pregnancy implants somewhere where the decidua is naturally absent, like in the case of an ectopic or an abdominal pregnancy, there tends to be an absence of this regulation. This allows the trophoblast to aggressively invade through the muscle and serosal layers. About 80% of patients with placenta accreta spectrum have a history of previous caesarean section, curettage, or myomectomy. Because of this, it's thought that uterine surgery is probably to blame. Uterine surgery leads to scarring, which causes changes and remodeling of the uterine tissue that can predispose to abnormal placentation.
Okay, so that explains how placenta accreta occurs in patients with previous uterine surgery. But we know that placenta accreta can still happen in patients without previous surgery, even those in their first pregnancy. How does that happen?
Well, certain conditions might be associated with microscopic endometrial defects that interfere with the normal function of the decidua. But there is also some suggestion that altered estrogen levels at the time of embryo implantation may lead to excessive trophoblast invasion as well. And this is especially true in IVF pregnancies. It's actually thought that placenta accreta spectrum may result from a combination of many factors, including defective decidua, abnormal trophoblastic attachment, abnormal angiogenesis, and vascular remodeling and progressive uterine scar dehiscence. In fact, with placenta percreta, it's not actually caused by the villus trophoblast invading all the way through the serosa at all. In most cases, the percreta is due to complete or partial uterine rupture, dehiscence or adhesions between the lower anterior uterine segment and posterior bladder wall, and this allows the trophoblast direct access to the serosa and beyond.
And how often is this happening? Are we dealing with this as frequently as Draco Malfoy's jibes, or is it more of a rarity, like a Dementor?
Placenta accreta occurs in about 1 in 2,000 pregnancies. With the rising rate of caesarean sections, we are definitely seeing it more and more. In fact, the incidence of placenta accreta has increased tenfold since the 1980s, and it's coincided with the increasing rates of caesarean delivery. Placenta accreta is also much more common than placenta increta or percreta.
That's crazy. Okay, so obviously having a previous caesarean section is a risk factor for placenta accreta, but we know it can happen in people with no previous surgeries. Who exactly is at risk of placentas gone wild?
The most important risk factor for development of placenta accreta spectrum is placenta previa after a previous caesarean section. As we mentioned in a previous episode, the frequency of placenta accreta spectrum increases as the number of caesareans increase. In the presence of placenta previa, if the patient has had no previous caesarean sections, the rate of placenta accreta spectrum is 3%. With one previous caesarean and a placenta previa, the risk of placenta accreta spectrum is 11%. With two previous Caesars and a previa, the risk is 40%. And with three previous caesarean sections and a placenta previa, the risk of placenta accreta spectrum is 61%. Once we get beyond 4 caesarean sections with a previa, the risk of placenta accreta spectrum rises to 67%. Now, in the absence of placenta previa, the frequency of placenta accreta spectrum at caesarean section is incredibly low. We're talking less than 1% for up to the 5th caesarean section. Once you get to 6 or more caesarean sections, the chance of finding placenta accreta without a placenta previa is almost 5%.
Uterine surgeries can also increase the risk of a placenta accreta spectrum. In particular, we're thinking any surgery that impacts on the endometrium. It's been associated with things like a D&C, manual removal of placenta, a myomectomy with breaching the cavity, a corneal resection of ectopic pregnancy, endometrial ablation, and hysteroscopic resection of intrauterine adhesions. Other risk factors include advanced maternal age, multiplicity, assisted reproductive technology, a history of a pelvic irradiation, history of postpartum endometritis, uterine abnormalities such as a bicornuate uterus, adenomyosis, and submucosal fibroids, and myotonic dystrophy.
Myotonic dystrophy? That's a bit random. What's the deal with that?
At this point, we don't really know why myotonic dystrophy is associated with placenta accreta, but there are quite a few case reports in the literature documenting the increased risk of placenta accreta spectrum in patients with myotonic dystrophy. One case series of 66 patients actually reported a 10% prevalence of placenta accreta spectrum amongst pregnant women with the condition.
Wow. I must admit, I've never heard of that before. There you go. So now that we know what placenta accreta spectrum is and who it's more likely to affect, let's find out how we can spot it in the wild. How do we diagnose placenta accreta spectrum?
So, firstly, you want to be alert and aware of the possibility of placenta accreta. If a patient has had a previous caesarean section and her morph ultrasound shows an anterior low-lying placenta, that should be a big red flag, reminding you to think about placenta accreta. This is also important information that you should put on any ultrasound request forms. Ultrasound is typically the first-line investigation for the diagnosis of placenta accreta spectrum. Most placenta accretas are identified on the morph ultrasound in patients with risk factors. Less commonly, placenta accreta may be an incidental finding during routine ultrasound examination, and sometimes the diagnosis is not made until delivery of the placenta.
This is not a situation you want to be in. Coming across an undiagnosed placenta accreta at the time of delivery is one of our worst nightmares. In these situations, your first suspicion of accreta might only be when the patient is having a sudden, massive, life-threatening hemorrhage while you're trying to do a manual removal of placenta. The problem here is that all or part of the placenta remains firmly attached to the uterine cavity, and you can't get a clear plane of separation. Attempts to remove the placenta can result in severe bleeding.
I think there's also this universal fear of coming across an undiagnosed placenta accreta when you're doing a Cat 1 Caesar in the middle of the night.
Absolutely.
Okay, so what are the features we're looking for on an ultrasound scan that would suggest a placenta accreta spectrum?
Now, here is a great exam question. The ultrasound findings of placenta accreta spectrum include loss of the clear zone, myometrial thinning, abnormal placental lacunae, bladder wall interruption, abnormal vascularity or bridging vessels, placental bulge, focal exophytic mass, and placenta lacunae feeding vessels. Now, at first glance, this might seem like a bunch of random features that you have to remember. But if you think about placenta accreta logically, it does all make sense. Firstly, there's loss of the clear zone. The clear zone is a hypoechoic area behind the placenta that is found with normal placentas. If this clear zone is missing or irregular, that can be a sign of placenta accreta. The absence of the clear zone indicates a loss or deficiency in Nitterbuch's layer and the subsequent fusion of placenta and myometrium into a single structure.
All right, quick segue. Who is Nitterbuch and what is the Nitterbuch layer?
I thought you'd never ask. The Knitterbuck layer was discovered by Reza Knitterbuck, or Knitterbuck, not sure, who was a Russian pathologist known for her histological studies of the human placenta. The Knitterbuck layer refers to the layer of fibrin that separates the uterine decidua from the fetoplacental trophoblast. This layer is the site of detachment of the placenta from the uterine wall after delivery of the baby. Knitterbuck is the only woman whose name is affiliated with a macroscopic anatomical structure. She was also the first person to describe the spiral arteries, which connect the uterine and placental blood flow during pregnancy.
What a Wonder Woman of obstetrics. Okay, so the next ultrasound feature we might come across is myometrial thinning. The myometrium behind the placenta can sometimes be less than 1 millimeter due to a previous Caesar scar or placental invasion. Then you look for placental lacunae. These are large, irregular, sonolucent spaces in the placenta at the area of accreta. Lacunae occur when the trophoblast reaches the large arterial branches of the uterine artery. High volume, high velocity blood flow from the abnormally dilated deep arterial uterine circulation leads to formation of placental lacunae. They actually give the placenta this moth-eaten appearance. Now, lacunae should not be confused with vascular lakes, which are completely normal findings, or with partial hydatidiform moles. Lacunae in placenta accreta spectrum are more numerous and irregular in shape, and the underlying myometrium may be thinned. The risk of PAS is highest when there are more than 3 large lacunae with irregular borders and high velocity or turbulent blood flow.
The next features we look for in ultrasound can be more suggestive of placenta accreta. Firstly, we have disruption of the bladder line. Normally, there is a continuous white line seen on ultrasound that represents the interface between the bladder wall and the uterine serosa. This line can be disrupted by placenta accreta or in the presence of neovascularity related to placenta accreta or increta. Abnormal vascularity is also a pretty clear sign of accreta. Vessels that extend from the placenta through the myometrium and either into the bladder or through the serosa are very obviously placenta accreta, and these are also termed bridging vessels. If a portion of the uterus attached to the abnormally adherent placenta balloons into the bladder due to weakness of the underlying thin myometrium, then you might also get a placental bulge or an abnormal uterine contour. And if you see a clear exophytic mass that breaks through the uterine serosa and extends into the bladder, you've got a slam dunk placenta accreta.
Now, it's important to point out that you don't need all of the findings to be present to diagnose placenta accreta. Also, a posterior placenta can be much more difficult to visualize and rule out PAS. Placental lacunae and disruption of the interface between the bladder wall and the uterine serosa have been suggested to be the most reliable diagnostic sonographic findings with a specificity of over 95%. But it's important to note that ultrasound is not 100% reliable in the diagnosis of placenta accreta spectrum. When I was doing my ultrasound term, this is when I was studying PAS, I asked the sonographer, what are the features of PAS? The next patient, the sonographer just looked at me and was like, it's your fault. And the patient definitely had a PAS. Carla, do we know how good ultrasound actually is at detecting placenta accreta?
Ultrasound done by an experienced sonographer is actually very accurate at diagnosing placenta accreta. In experienced centres, we quote a 90 to 95% sensitivity. However, not every scan can be done at an experienced centre, and it's important to note the placenta accreta spectrum remains undiagnosed in half to 2/3 of cases. Antenatal diagnosis of PAS definitely improves maternal outcomes, and so it's incredibly important that we pick this up in advance when we can.
How early can we diagnose placenta accreta accurately?
The ideal time to detect placenta accreta on ultrasound is between 18 to 24 weeks gestation. However, there are features on the first trimester ultrasound that may lead you to suspect placenta accreta spectrum earlier. For example, a gestational sac located in the lower uterine segment, or the presence of multiple irregular vascular spaces within the placental bed. Caesarean scar pregnancy may also be diagnosed in the first trimester and is strongly associated with subsequent placenta accreta spectrum if left untreated.
All right, so what about MRI? Surely MRI would be way more accurate.
A lot of people do think that if you suspect placenta accreta, then the patient definitely needs an MRI, although this is not always the case. MRI is not necessarily more accurate than ultrasound. Ultrasound continues to be the first-line imaging tool for the screening and diagnosis of PAS. MRI has been reported to have a very high sensitivity and specificity for the diagnosis of PAS, However, it's not yet been proven to be superior to ultrasound, and it's important to consider its reported accuracy and context. MRI is not usually employed as a screening tool in women at higher risk of PAS. Typically, only women who have a suspicion of PAS on ultrasound are referred on for an MRI. This means that the prevalence of placenta accreta in patients who undergo MRI is higher, which may lead to an overestimation of the diagnostic capability of MRI. There are also downsides to an MRI. It's more expensive, less widely available, and there is limited expertise to interpret these studies, particularly on how to interpret placental appearance. In a recent study, MRI resulted in a change in diagnosis that could alter clinical management of PAS in more than 1/3 of cases. But when changed, the diagnosis was often incorrect.
MRI does have a role in diagnosing and assessing the extent of placenta accreta, doesn't it? Especially in those cases of PAS with a posterior placenta, those can be a lot more difficult to image with ultrasound.
Yeah, you're right. In general, ultrasound is adequate to diagnose and assess placenta accreta spectrum. However, there are some circumstances where MRI might be more useful than ultrasound. Firstly, when assessing a posterior placenta accreta spectrum. Secondly, when assessing the depth of myometrial, parametrial, or bladder involvement. And thirdly, evaluating the myometrium and placenta at the most lateral portions of the hysterectomy, because this area is not very well visualized by transvaginal ultrasound. MRI is typically recommended as a second-line imaging tool for placenta accreta spectrum to assess the depth of invasion and lateral extension of myometrial invasion, especially in those cases we just described. If an MRI is performed, the ideal timing is between 24 to 30 weeks gestation. This is because false positives and false negatives are more likely earlier and later in gestation.
MRI is also quite safe for the fetus, especially if we don't use gadolinium, which we typically don't in pregnancy. So we've heard about the features of PAS that we look for in ultrasound. What are the MRI features that suggest placenta accreta?
Again, these can be remembered by thinking logically about the placenta accreta and are actually quite similar to the ultrasound findings. Myometrial thinning, abnormal vascularization of the placental bed, interruption of the bladder wall, placental bulge into the bladder, and a focal exophytic mass. Additional MRI findings include dark intraplacental bands on T2 weighted imaging, loss of retroplacental hypointense line on T2 weighted imaging, heterogeneous signal intensity within the placenta, disorganized vasculature of the placenta, and disruption of the uteroplacental zone. The more findings you have, the worse the prognosis.
All right, so we know how to diagnose PAS. What are we going to do about it? What's our plan of attack?
So antenatally, it's all about preparation and information. We firstly want to counsel the patient on the diagnosis of placenta accreta, as well as the possible outcomes. Multidisciplinary involvement is also key. Typically, we would refer to MFM and arrange an MDT meeting with anaesthetics, interventional radiologists, MFM specialists, obstetricians, neonatologists, urologists, and gynae-oncologists. These meetings are usually run at a tertiary centre and places that are considered to be a centre of excellence for placenta accreta. If your hospital is not equipped to deal with placenta accreta, then these patients are best referred to a hospital that is. The principles of antenatal management are essentially the same as for those with placenta previa. Optimize hemoglobin, avoid pelvic exam and rigorous physical activity, avoid intercourse, although again the benefit is largely unproven, and manage as an outpatient unless symptomatic. Serial ultrasound assessments of the placenta are generally not useful after the diagnosis has been made. However, a scan at 32 to 34 weeks can locate the placenta and help to assess the likelihood of bladder involvement, which is useful for surgical planning and delivery. Serial growth scans are also not indicated for placenta accreta alone, unless there are any other risk factors for fetal growth restriction.
When it comes to delivery planning, there's generally two options: planned caesarean hysterectomy or conservative management. Caesarean hysterectomy is the gold standard management for the treatment of placenta accreta. This is because the placenta cannot be removed in any other way, and if we leave it in situ, the patient often experiences severe postpartum hemorrhage. Caesarean hysterectomy is typically planned for 34 weeks gestation. UpToDate recommends 34 to 35 and plus 6, and ARCOG recommends planned delivery at 35 to 36 plus 6. Keep in mind that a significant amount of patients develop complications such as PPROM, preterm labour, or antepartum bleeding, leading to delivery earlier than planned. For women at high risk of emergency delivery before 34 weeks, planned delivery before 34 weeks may be reasonable. Waiting beyond 36 weeks is not recommended because about half of women with placenta accreta spectrum beyond 36 weeks require emergency delivery because of hemorrhage.
Anticipating major hemorrhage is incredibly important. The patient should have 2 large bore cannulas. An arterial line is also inserted for additional monitoring. Blood should be cross-matched and at least 4 units available. The blood bank should be aware of the case in advance and have adequate amounts of packed red cells, fresh frozen plasma, cryoprecipitate, and platelets available at the time of delivery. The magnitude of blood loss is really difficult to predict, but the median blood loss has been reported to range from 2.5 to 7.8 litres. It's hard to know exactly how many units of blood are likely to be required, and studies have reported anywhere from 0 to 108 units needed.
108?
I know, water bleed. Ooh. Cell saver should also be arranged in advance. Autologous blood donation is typically pointless given that many patients will require more units of blood than they are able to safely donate antenatally.
Both general and regional anaesthetic techniques have been shown to be safe for surgical procedures required for the delivery of placenta accreta spectrum. Ultimately, the decision should be made by the anaesthetic team. An argument can be made for going straight to a GA since this allows the anaesthetist to achieve better hemodynamic control in the event of a major hemorrhage. Again, lithotomy position with a graduated drape is preferred to allow assessment of vaginal bleeding that may not always be appreciated in the supine position. An ICU bed should also be available for post-op care if needed.
Okay, let's talk surgical technique. How do we actually do a caesarean hysterectomy?
The first thing we need to consider is who actually does the surgery. With Caesar hysterectomies, you should expect intense vascular engorgement and challenging anatomy, and so having the most experienced pelvic surgeon involved from the outset is recommended.
The next thing we need to consider is the type of skin incision. If the placenta is anterior and extends towards the level of the umbilicus, often a vertical midline incision is required to allow delivery of the baby through a fundal or upper transverse incision above the upper border of the placenta. A large extended transverse incision, such as a maillard incision, can also be used.
Total hysterectomy is the preferred method due to the potential risk of malignancy developing the cervical stump, the need for regular cervical cytology, and other associated problems such as bleeding or discharge. This is always necessary if invasive placental tissue has been seen within the cervix on prenatal imaging. Bleeding from the lower uterine segment or cervix also usually precludes a subtotal hysterectomy.
In all cases of Caesar hysterectomy, the placenta is left in situ with no attempt to remove it. Typically, the baby is delivered through a fundal incision or a uterine incision in a location designed to avoid the placenta. You can actually perform intraoperative ultrasound on the exposed uterus to identify the upper placental edge and guide the decision regarding the site of hysterectomy. The cord is clamped and cut, and then the uterus rapidly sewn shut before performing the hysterectomy. Prophylactic oxytocin is not given routinely because it may increase the rate of partial placental separation and hence increase the risk of bleeding. Tranexamic acid can also be considered at the time of cord clamping to reduce the overall blood loss.
Devascularization of the uterine corpus is then performed, usually with dissection in the retroperitoneal space. However, the step can also be performed before delivery of the baby in order to minimize blood loss. In fact, in some centres, the procedure will actually start with division of the round ligaments, reflection of the broad ligament down to the bladder, and reflection of the bladder prior to delivery of the baby. This allows rapid completion of the hysterectomy following delivery of the baby. The value of preoperative ureteric stent placement is unclear and it's left to a case-by-case evaluation.
Postoperative management includes admission to ICU for intensive hemodynamic monitoring, watching for the risk of ongoing intra-abdominal bleeding, observing for complications such as fluid overload from resuscitation, renal failure, liver failure, infection, unrecognized ureteric, bladder or bowel injury, pulmonary edema, and DIC. It's also important to monitor for Sheehan syndrome, which is otherwise known as postpartum pituitary necrosis.
Okay, so what about if a woman doesn't want a hysterectomy? What if she really wants to have another baby and is absolutely opposed to the idea of a Caesar hysterectomy? What options does she have then?
Planned caesarean hysterectomy may be unacceptable to women desiring to preserve their fertility, and conservative management techniques for uterine preservation for both adherent and invasive placenta accreta have been used increasingly in many centres around the world. These techniques include leaving the placenta in situ and partial myometrial resection of the accreta area with myometrial repair.
Conservative approaches are usually reserved for two circumstances: when the intraoperative findings suggest that hysterectomy will likely be complicated and associated with a high risk of massive hemorrhage or adjacent tissue injury that may be reduced by leaving the placenta in situ, or for women who desire future childbearing or whose fertility is inextricably linked with social status and self-esteem.
In the conservative approach, the umbilical cord is ligated close to its placental insertion after delivery and without any attempt at removal. The placenta is left in situ and adherent to the myometrium. The use of adjunctive measures to reduce blood loss and to speed up the process of placental resorption or expulsion has been reported. These include methotrexate, compression sutures, balloon tamponade, uterine artery embolization, or uterine artery ligation. Unfortunately, no efficacy for any of these adjuncts has been proven. Uterine artery embolization has been shown to cause uterine necrosis, and the use of methotrexate has actually been linked with maternal death, and therefore these options are not recommended by any international consensus guideline and should be actively discouraged.
Placental resorption or expulsion usually takes from 4 weeks to 9 to 12 months, and the success rate is reported to be at 78%. Complications of conservative management include severe vaginal bleeding in 52%, 20% risk of secondary hysterectomy, sepsis in 6%, death 0.3%, the range 0 to 4%, and a subsequent pregnancy in 67%. Severe maternal complications have been reported in 6% of patients, including sepsis, uterine necrosis, uterine rupture, fistula, acute pulmonary edema, renal failure, VTE, and maternal death. Subsequent pregnancies have been reported with a risk of recurrent PAS of about 30%.
Local surgical resection has also been proposed as a conservative technique. This involves removal of the myometrium where the placenta is abnormally attached. This approach may reduce blood loss and improve maternal morbidity compared to hysterectomy. An appropriate case for consideration of local resection would be one with focal disease with an adherent area which is less than 50% of the anterior surface of the uterus. Management involves oversewing the bleeding sites or removing a small wedge of uterine tissue containing the focally adherent placenta.
So, at the end of these cases, we will usually send the placenta for histopathology. What are the findings of histopath that we need to watch out for?
Placental histopathology in placenta accreta will typically show placental villi anchored directly on or invading into or through the myometrium without an intervening decidual plate. The placenta is characterized as an accreta, increta, or percreta, depending on the depth of myometrial invasion.
And how can they diagnose focal accreta? You know those cases where you have to do a manual removal of placenta, but it's really difficult and part of the placenta is really adherent? If you actually manage to send that placenta to the lab, how can they even tell if it's placenta accreta if you've managed to separate it from the uterus?
So the pathologist may be able to identify focal accreta without receiving a uterus specimen. If they can identify curettings showing myometrial invasion with no decidual plate, or if there are fragments of myometrium adhered to the placenta.
Okay, so let's go through a couple of curly situations. Let's say you're doing an elective Caesar, and upon opening the abdomen, you see several large vessels protruding through the myometrium and into the bladder. You immediately suspect you've come across a previously undiagnosed placenta accreta. What should you do?
Panic.
Yeah, that's what I said in my head.
No, so if the mother and baby are both stable and you suspect she has a placenta accreta or percreta, you should stop what you're doing immediately. The caesarean should be delayed until the appropriate staff and resources have been assembled and you know you have adequate blood products available. This might actually mean that you have to close the maternal abdomen and transfer the woman to a specialist unit for delivery. If staff are available, but just not immediately, you can also cover the uterus with warm packs and delay further surgery until the appropriate personnel and resources are available. If the mother is bleeding heavily or the fetus is compromised, the best option is delivery through a hysterectomy far from the placenta, followed by closure of the uterus with the placenta left undisturbed. This can then be followed up with a delayed hysterectomy.
Okay. What about if you're doing a caesarean, you've delivered the baby, but you can't seem to be able to separate the placenta from the uterus?
In this case, you should leave the placenta in place and close the uterus, or leave it in place, close the uterus, and proceed to a hysterectomy. Both of these options are associated with less blood loss than trying to separate the placenta.
Okay, so that wraps up a mammoth episode on Placenta Accreta. Let's give you a quick recap of everything we've covered.
So, Placenta Accreta spectrum is a term used to describe abnormally adherent placentas. It includes Placenta Accreta, where the villi are superficially adhered to the myometrium, Placenta Increta, where the villi deeply penetrate the myometrium, and Placenta Percreta, where the villi perforate through the serosa to surrounding organs. The incidence of Placenta Accreta spectrum is 1 in 2,000, and it's rising with rising Caesar rates. The prevailing hypothesis of Placenta Accreta spectrum is that an iatrogenic defect of the endometrial-myometrial interface leads to a failure of normal decidualization at the site of a uterine scar, enabling abnormally deep trophoblast infiltration. Risk factors include previous accreta, placenta previa and a previous Caesar, previous uterine surgery, advanced maternal age, multiparity, assisted reproductive technology, history of pelvic irradiation, history of postpartum endometritis, uterine abnormalities such as a bicornuate uterus, adenomyosis, and submucosal fibroids, and myotonic dystrophy.
Diagnosis is made by ultrasound, which is the first-line imaging, ideally 18 to 24 weeks. MRI can be used as an adjunct to assess depth of penetration and lateral involvement, as well as to assess a posterior placenta. It's most accurate at 24 to 30 weeks. Ultrasound findings include loss of the clear zone, myometrial thinning, placenta lacuna, loss of the bladder uterine interface, placental bulge, exophytic mass in the bladder, abnormal vascularity or bridging vessels.
Management of Placenta Accreta spectrum includes a multidisciplinary team meeting, optimizing the hemoglobin antenatally, pelvic rest and avoiding strenuous activity, and delivery planning at a center of excellence. Caesarean hysterectomy is the gold standard of management and should be done at 34 to 35 weeks. Conservative measures can be considered for those wishing to preserve fertility, for those where hysterectomy has a high risk of causing damage to surrounding organs, or for those with focal accreta. Conservative management options include leaving the placenta in situ and focal resection of the involved myometrium. Complication rates of conservative management remain high, and adjunctive treatment such as methotrexate is not recommended.
And that wraps up this week's episode of the Uterine Sound Podcast. Keep an eye out for our summary slides on Instagram later in the week. If you have any comments, feedback, or want to fact check us, please reach out by email at theuterinesound@gmail.com or on Instagram and Facebook at The Uterine Sound.